Thank you, Sheila, and good morning, everyone. I just want to say that this is a real pleasure for our department to be able to share with you some of the insights into really important topics of our time. This is a wonderful opportunity to also network with you and to get to know you. Just a little background, when I came in 2010, we were charged with building one of the really great academic medical centers, one of the great academic radiology departments. And I've always had a very strong clinical basis. When I trained at New York University, it was a busy, busy place in which academics filtered into clinical and was mutually informing. We've created that environment at UT Southwestern. I'm very proud of the department and frankly really pleased with this event. So I'm grateful to Drs. Brewington and Pedrosa for planning this. And there were way too many people, but all the people within the department who have been instrumental in making this event happen and realizing the true value of this program. Well, I'm going to be talking to you today about more of a political perspective, leaving a lot of the radiology to others, but it's important to frame our discussions in the context of our new world, which MACRA is certainly a part of, but really it's a focus on how we are looking at imaging in a value-based world, MACRA being just one component of that transition. You know, it all starts with some of the discrepancies that we're seeing in healthcare, and these can be seen when we compare the expenditures in the United States compared with other industrialized nations, and we compare those with certain critical metrics. This article from Stephen Brill in the New York Times highlights the U.S. as being ranked as the worst amongst industrial nations for the fifth time in a 2014 Commonwealth study. This has not changed significantly in the last 2 years, because comparing the dollar spend to certain critical metrics such as infant mortality, childhood obesity, and life expectancy, we were doing terribly. What's even worse, though, folks, is more recently, it's been shown that our access, efficiency, and equity pale in comparison to the other industrialized nations. Just to highlight how things are discrepant, we had a recent visitor who was training with us from Nigeria, and I asked him how many MRIs they have in Nigeria, and for a population of 173 million, there were 3 MRIs. At UT Southwestern, we have 21 to serve a metroplex population of somewhere close to 8 million. So we certainly are abundant in technology, but is that the measure of success? The healthcare expenditures as a share of GDP, you can see here, this has not changed much. The last figures I've seen are between 17.8 and 18.1%, again eclipsing the values of other industrialized nations. We also can look at the U.S. national healthcare expenditures, and here we're seeing that the actual spend just keeps rising, although the percent growth has been curbed a little bit. Now, this rising change is fueled by a variety of sources, of course influenced by the changing demographics of our nation, with more increased elderly people prone to chronic diseases. And those diseases, diabetes, CHF, and chronic HIV, so a success converting HIV from a death sentence to a chronic disease has absolutely transformed taking care of people and their lives, but comes at a significant cost. In other words, you can't improve health care across the board and expect costs to drop and plummet. We've got to work the system more carefully. When we look at Medicare spending as a subcomponent of the national health care expenditure, you can also see over time that the annual percent growth is really being curbed over time. There are some little blips going on, and we'll wait to see how things pan out over time. But overall, there has been a curbing effect, some of that attributed to the Affordable Health Care Act. The problem really is, in the end, is health care a right or a privilege? And despite where you sit on that spectrum, we really have to make critical decisions of the want, need, and afford trade-offs that exist in anything that we do, healthcare being paramount in this discussion. So the Affordable Care Act, which was approved in 2010, remember that's the Patient Protection and Affordable Care Act. So some people call it the PPACA, other people call it Obamacare, was really geared towards trying to achieve quality, affordable health care for all Americans. And in that, there was improving coverage was a key element, and we can see all these elements here, which, as you know, now are up for scrutiny with the recent bill that was passed by the House just this week. So the Affordable Care Act, or Obamacare, wants to cover more people, expand the Medicaid program, and support innovative medical care delivery systems. This is a component that I think has been underemphasized in its importance because it is that experiment and funding for such innovative programs that allows us to pursue new opportunities for savings in our healthcare systems. So as I alluded to, we saw this just yesterday that the bill passed by the House. It faces the Senate test. There's a lot of controversy behind this. We'll just see where it pans out. But I want to draw your attention that ultimately MACRA, which I'll speak to in a moment, is not Obamacare. MACRA is distinctly different legislation. So here we are. The Patient Protection and Affordable Care Act is not MACRA. I don't know what's going to happen to the Affordable Care Act. You know, it's tumbling around. MACRA is here, and I'm going to defend that position in a moment. MACRA was designed to replace the flawed sustainable growth rate. If you remember, that was a very flawed program of formula for physician payments, and they just kept kicking the can down the road, down the road, down the road, and they finally said, we can't do this anymore, and that's where MACRA came in. But MACRA had very important components that emphasized quality. The reason I believe it's a rock and it's here to stay, that was truly bipartisan legislation developed by a Republican Congress and signed by Obama. So because it was bipartisan, this is here to stay. Now, the health care itself, Obamacare, we don't know where that's going. MACRA's here, and MACRA includes a very strong component emphasizing quality. One of those, just one example, is the bonus payment for physicians who engage in qualifying alternate payment models such as ACOs, medical homes, and bundle payments. But the message, folks, emphasis on quality is here, and I'm going to talk about what quality and value are in a moment. So there's a lot of emphasis on reducing expenditures. And how will we do this? Well, the mantra lately is conversion of fee for service. That is, everything you do, you get paid regardless of what it does or doesn't do for a patient, versus payment for the performance or the value that you actually provide, that we provide for our patients. This really goes from a physician-centric perspective to a patient-centric perspective, goes from subjective to objective. I can't tell you how many times I hear, well, I've always done it this way, and there may be evidence-based approaches to the way we should be practicing medicine. Well, that's not the way I was trained. That's extraordinarily physician-centric. That is dissolving, that will be disappearing, and we need to work together to get to best practices so that we can have informed practices, continue to mature in the way that we approach our care. Other examples of ways in which expenditures can be reduced is the increased bundled payments. We've seen that a lot in imaging, where it used to be an abdomen and pelvis, which take separate evaluations and separate time, were bundled into one payment, and we're seeing more and more consolidation of payments throughout medicine. The ultimate concern is, will we be capitated? And at that point, we just have a dollar per month per member kind of reimbursement, and then things become a cost center. And what we must do then, we absolutely must be thinking about how efficiently we take care of individuals. This is the big tension that exists now. Is medicine a for-profit endeavor, or is it something that is an obligation to people? This is the very thorny debates that are going on right now with our politicians. But imaging's been a very easy target here because we've had a history of rapidly rising expenditures, and I would argue because of utility. I mean, there are some incredibly terrible abuses. But when we think about the fact that there are very few exploratory laparotomies, When we think about the fact that we have reduced the negative lap rate for appendicitis from 20% to 5% with the utilization of CT, those are good things, and those actually are ways in which, quote-unquote, expensive technology saves money. But the lack of standardization, where people may get blanket tests, I've still seen some cases in which an OBGYN is getting a KUB before an operation. Overutilization, sometimes defensive medicine, inconsistent utility, things that are developed and just done by habit rather than by proof and evidence. And these are often indirect contributions to healthcare. These are the examples in which the legislators have sought to reduce and control some of the ways in which imaging costs have been on the rise. When I talk about some of the problems, I'm not just talking about the ordering, it's also what some of the radiologists do. I mean, doesn't it drive you nuts? Clinical correlation recommended. You know, I teach our residents, I say, do not say this. Cannot rule out, and you get a laundry list of possibilities. You know, yeah, you can't rule out Markia-Favre Bignami disease. Okay, that's fine. Recommend additional imaging. I remember having a very difficult debate with one of my mentors where he said, you know, no wonder clinicians hate us. You know, you earn a good salary, you have a good lifestyle, and all you do is order another test. Well, we seek to do much more than that, and I'm very confident that UT Southwestern, we do that. You'll hear about that all day today. So I've been thinking a lot about this, and I'm taking a course in healthcare administration. And I wrote a paper on imaging utilization, and I thought there were two ways to think about it. What are the principled utilization drivers, and what are the non-principled drivers? Well, a principled approach would say, okay, can we offer a non-invasive evaluation that's effective and efficient and can replace something that's more dangerous and more costly? Can this lead to an early and accurate diagnosis that leads to actionable change that's meaningful for a patient? Is there any unique capability for detection and characterization to facilitate management? Early monitoring of response to therapy, early go, no-go decisions for treatments. So if there's an expensive therapy that's toxic, can we say, based on one early imaging evaluation, this is a waste of time, stop. This is particularly pertinent in cancer therapy. Realization of improved outcomes in partnership with all the new therapies that are coming in. Can imaging help guide and inform? Things like reducing length of stay by making good decisions based on the imaging finding, and very importantly, facilitation of emergency department triage and dwell times. But non-principled imaging utilization drivers are defensive medicine, even in Texas with tort reform. There's plenty of people who say, well, I'm really nervous about it, I just want to be sure. How many times do we want to be sure? And that may not be a principled approach. Financial incentives, you know, one of the, I don't know if you know this, but one of the, probably the largest utilized imaging entity is echocardiography. Is that because it's essential? Is there a financial incentive? Some of it is the distorted perspective of our world. It's been shown time and time again through governmental resources that the highest utilizers of imaging are clinicians who have their own imaging equipment in their practices. Misguided patient preferences. What happens when the patient presses you and us to say, well, you know, I really need an MRI, and do we actually bend to that need because it's just easier and quicker to say, oh, go get the test. Reduce clinic throughput pressure. So, you know, how many patients you see per hour? Forget it, I'm not going to evaluate, let's just get a test. Inattention to appropriateness guidelines. Some of these are really well developed, and there's a lack of adherence to many of these. Repeat of inadequately performed exams. This one drives me nuts because we get CDs, sometimes we can't read it. Then we finally, you know, get our clever IT people and we read it and it's a piece of junk and we can't actually make a decision on it. So what you'll also hear me say during the course of this talk is imaging is not a commodity. It is not a commodity. It is not a commodity. And finally, sometimes we get this insufficient patient history. We'll sit there and we'll say, you know, rule out blank, you know, or patient with pain, and that's not really helpful. So the partnership is critical in getting the best test for the person, right test, right time. The extreme case in which we would be controlled could be this capitated position. And here, imaging is viewed as a cost center, and that could place pressure and just reduce expenditure. And unfortunately, this blanket reductionist approach can be very negative on the impact for patient care. And my counterpoint is that we need to demonstrate imaging's value to everyone, not just an ACO, so that we get the right treatment to the right patient at the right time, and that we can show that our aggregate costs can result in savings through effective and efficient utilization of these technologies, that our practices be data-driven, that we discontinue ineffective and costly treatments at an early time, that we are an integral part of appropriate utilization. So I just want to point out to you that the ways in which imaging has impacted the standard of care, I've talked about some of these before, but when we were in Boston, Dr. Pedrosa showed that MRI for pain and pregnancy can reduce the negative laparotomy rate. Again, we reduced that down to 7%, and if you know, in pregnant patients, the accepted negative lap rate is up to 50%, between 25 and 50%. CT for adrenal masses. We have CT for blunt trauma, MRI for prostate cancer, and low-dose lung cancer. So debunking imaging as a target, is it really that costly? Well, data have shown that cancer imaging tests cost less than 6% of the total Medicare costs, and diagnostic tests in general, of which imaging is a subcomponent, influence an estimated 60 to 70% of all treatment decisions, but account for only 5% of hospital costs and only 2% of Medicare expenditures. So, we think of it, it's easy to say, oh, the MRI is $1,000, let's cut it by $800. But when you integrate it in the context of all healthcare, it's actually not that expensive. And if we think of the way in which it drives important decisions, if utilized appropriately, it's a win. So we can decrease image utilization and expense, but appropriate utilization is important. Like I mentioned, what would happen if we just started cutting? We might see delayed discharges. We could see unnecessary admissions, inaccurate patient assessments with grave consequences on our patients. And when we look at healthcare expenditures and you size up imaging against pharmacologic costs, the cost of treating index chronic diseases, just CHF, diabetes, and cancer, and the extensive amount of expenditure on end of life, imaging becomes a fragment of that. And the new value proposition is that we need to partner. As your partners, we seek to help create really important, actionable information for the decisions about patient care. We want to achieve this with high accuracy, faster speed, and lower cost. And we want to do this by being very important about the indicators of success. And I've sketched this out for us. If you think about everything that happens, there is a patient who before a visit has a concern. You will take a look at them. We will subject them to some kind of intervention that has cost, it has time, it has safety, it has satisfaction implications. Whatever we do, maybe that's imaging, maybe that's an evaluation, maybe you medicate, maybe you refer for a procedure. There is then an after-visit experience of the patient, and they and we will be determining, have we impacted survival? Have we changed the symptoms? Is there an improvement in the quality of life? Did we achieve a diagnosis? Did we change the medication? Did we change the management? Did we change the disposition? Did we get the patient out of the OR or into a hospital bed quickly? These are the ultimate determinants, and these are an array of both short and long-term outcomes. In the end, we need to be looking at value. Michael Porter from the Harvard Business School determines has mentioned that value can be seen as quality over cost. I actually like an extension of the concept to patient outcomes per dollar expended. So outcomes always show up in this. In our world in imaging, right test, right time, which is what we're all about today. But I also want to add expert interpretation with expert guidance, and that's one of the things our department can do because of the quality of the individuals and because of the continued investment UT Southwestern Radiology makes in innovation. Innovation cannot die, and innovation distinguishes a department like ours from the commoditized imaging that you can get out in the community. So you're going to hear about back pain later today, but I just want to tweak your interest with this. You know, who's really benefiting from all this excitement about back pain? We spend $85.9 billion a year trying to treat back pain. Experts say about half of that is unnecessary. So that's a lot of money. What could we do with the $43 billion saved? So because I'm interested in innovation and academics, I'll ask you this. What was the 2016 NIH budget? Anybody know? $32.3 billion. We can double the NIH budget and still have $10 billion left over if we just cut out unnecessary back care. Well, that's just back care. So it shows you the magnitude of some of the problems we have with fee-for-service, financially motivated care. Now, even if this is only half right, think of the savings that still exist. But innovation can't die. Okay, so we've got to keep building the next best thing, provided we are pushing the technology towards something that will be efficacious for our patients. So I'll share with you some things that we've done in the past. This is a patient who was being planned for an indwelling neurostimulator. For those of you who don't know, these are electronic leads that exist in the brainstem. Localization of these is important. When you subject somebody to MRI, the power deposit can heat up the ends of the electrodes and actually cause tissue ablation. We don't necessarily want to do that. So we developed a technique in which we have reduced the power to the point that the temperature is not raised. This is something that a place like UT Southwestern can do that, mom and pop radiology out there cannot do. Do you know all the time that your patient has a neurostimulator if you're looking at maybe they have a irritated bladder? So we're not a commodity. Fast breast screening. This is innovation that occurred originally out of Germany with Christiane Kuhl, starting with an array of a protocol that lasted a long time. And she said, what if we just cut this all out and had a very abbreviated protocol? And we could cut this scan time down immediately, which is really a satisfier for our patients. They're only in the magnet for about 5 minutes. And we can increase our throughput and reduce our costs. And here are the results of comparing the abbreviated to the full protocol, and I'll just highlight, if you're doing a screening exam, they pretty much hit it out of the ballpark, even with the abbreviated examination. So we're not a commodity. You'll hear more about prostate. We do endorectal coil imaging. We detect cancers that others do not. This is the routine pedestrian approach out in the community. You're fine, sir, and we found a cancer. Not only that, we're able to quantify this cancer, and we can tell that it is a high risk for being a high Gleason grade. I'm working with Klaus. You'll hear from Klaus in a moment. We have changed the standard of care locally by greatly increasing the positive biopsy yield of significant cancers, not insignificant and incidental cancers. So we're not a commodity. And in the end, these oncologic outcomes, can we impact the significant cancer detection? Can we reduce the time to definitive treatment? Earlier treatment in prostate may also imply the opportunity for nerve-sparing options, especially with highly delineated anatomy. And we make informed decisions about less invasive management options. This is real value. This is an outcome divided by cost that results in a favorable condition for the individual, the patient, for a healthcare system, and ultimately integrated up into society. So conclusions, value-based perspectives will survive the Trump administration. The role of the radiologist is changing. We're your partners. We are the information aggregators, and we're interested in innovating with you to provide more value for your patients. It's needed. Innovation is constantly needed because we are not a commodity, and we seek to continually provide increased value with high accuracy, faster speed, lower cost, in a patient-centric manner. So I'm happy to be here with you today. I'm looking forward to the feedback about your experience and your ideas and thoughts on these topics, and I appreciate your attention.